name is Jean Bishop. I've been a primary care physician in Philadelphia for 30 years. First, and I guess I should give a second part to that, which is that, as some people in this room know who are my patients, I left practice a few years ago because I decided it was more important to fight to change the healthcare system. I know I need to get to a question. I just need to say something to Bill Golderer, which is the last time I was in this church, I was here to see a performance of Don Quixote. And it was a terrific performance, and I didn't think until I got here today how apropos it was to be on a quest. Don Quixote wasn't looking for national health insurance, but I am. And I'm going to be very upfront, and then I'm going to ask you a question. I'm a longtime member of Physicians for a National Health Program. I do believe in my heart that single payer is the best thing for quality health care. But I am not Don Quixote. I'm a little more realistic. So I want to share a story and ask how you think the current bill will address this. When I was seeing patients, I saw a woman in a Medicare HMO. Now, Medicare nicely covers everybody. The Medicare HMOs, which people think are cheaper, have many hidden rules. Right. And she came to me, and she was having a concern, and I really wanted to send her to a cardiologist. And I was a very long-term primary care doctor. If I thought somebody needed a cardiologist, they needed a cardiologist. And she said, I can't go until next month. And I said, what do you mean? And she said, well, my copay for primary care is $5 or $10, but my copay for a specialist is $20, and I won't have that until the beginning of next month. So this is a way. She won't have the $20, right. So the problem is that private health insurance companies, which is what Medicare HMOs are, use a lot of, even if you let everybody get insurance, use a lot of hidden devices, rules, which people are clueless about before they sign up, that in effect ration care way more than Medicare or any other system that we could think about. How are you going to get these private insurance companies that are going to continue to survive to be upfront about those rules and to not do what is very clearly rationing care?
Yes, thank you. And I should have said there was a third thing that has to be in the bill that passes. And that is, there is an established minimum level of benefits that have to be in the bill. That you will have the right to screenings and types of treatments no matter what. And this is reviewed by a board where there are even patient advocates with an ombudsman or woman that you can complain to. And I'll tell you, we see it in our office all the time. A young couple stops in, they have a young son, stunted growth. The healthcare plan says we don't cover that hormone growth that your doctor wants. A woman with cervical cancer, type of chemo, the insurance company says we don't cover it. We had to get involved. And so what it does is it addresses this several ways. There is a level that is set that every healthcare plan in America must meet. Number two, because again, if you do get that person in there to get that preventive or that screening, that they often, and I'm going to get to the issue of cost, can't afford or are denied, and in this case, this is how we're not going to deny it, then we're all more, if we catch it early, have a productive citizen. Number two is the issue of cost. We are going to it is mandated that when you pay, whichever healthcare plan it is, that these preventive copays are free. No copays once you come in. Number two, we limit out-of-pocket expenses per individual to $5,000, period. And for a family, it's $10,000, period. Third is what we do is that it cannot be more than 12% of your income. As another effort to say, we want you to be able to afford what your health care is. The fourth thing we do is take advantage much more of her specialty. We do not take advantage, nor do we value in the types of rewards that a general physician should get. We have two pilot programs in this bill, and I wish we were going even more, but I think it's a beginning to where I think you need to go. We incentivize doctors today on what's called fee for service. You come in, you get rewarded for that visit. Here's your pay. You come back, you get rewarded for that visit. You're not incentivized for the quality of the health care of the person at the end of the year. So what we're trying, in this bill, we have two large experiments set up to where we say, okay, general physicians, let's say there's 300, 400 of them. Here's a network of people, 100, 200, 300,000. Here's your payment. At the end of the year, if they make this and they're tied into networks of specialists, and they're all tied together. If these people are healthy at the end of the year, based on statistics of what they should be, you get to keep more of the money. You're incentivized exactly differently than today, not for the quantity of visits and preparing whatever they come in with, but for the quality of their health care at the end. This is a massive change that makes people more healthy and eventually bends the cost curve. And the other thing is, I'm co-sponsor of two bills, and I'm happy to send them to you, where we actually try to get people, instead of just going to surgery where there's more, we try to incentivize by paying more for their tuition, medical costs, to get the general physicians in there. This is something they tried wrongly with HMOs in the past. This is a different approach that people think can begin to push that cost curve down.